Okay, hi. So yes, today we are here to discuss our part 4 of the DNB paper of 2021, December 2021, part 4. Okay, and today what we are going to do, we are just going to discuss about trauma. We are going to discuss about the ATLS and the splenic injury. That's what we are going to discuss in today's session. Okay, now, okay, so as you can see, none of the students is there live at this point of time, but yes, okay, I hope that you are watching this on the recorded kind of a thing. Okay, so in today's thing, what we are trying to kind of talk about is an ATLS guidelines and the splenic injury. That's broadly what we are going to talk about. Okay, now ATLS, advanced trauma life support, we all know, right? So we have ACLS and the ATLS. As the surgeons, what you basically follow is an ATLS. So the first part of the question was enumerate the basic concepts of ATLS. Now, ATLS, if at all you describe in depth, that's going to be a massive, massive thing. But in your question for 5 marks, they had asked you about the basic concepts of the ATLS. So let's kind of stick to the Sabiston, like what Sabiston basically writes. And then I'll give you a couple of more points which are there here and there in the 11 video or something like that. I'll just enumerate those as well. Okay. Now, ATLS overview. So all these particular things, obviously, you are not going to kind of write in the exam. You will not even remember that. That's all okay. It's just for you understanding. Okay. So the ATLS was basically developed in 1980 and provided a standardized approach towards the trauma care. Over 1 million healthcare professionals are trained in 86 countries and focused on quickly identifying and treating the life-threatening conditions and the trauma patients. So that's all fine. That is the basics of the ATLS. Obviously, you will not be able to remember these statistics and not relevant at all. But the key components of the ATLS, like what are the major key components of the ATLS? Treat the greatest threat to life first. Okay, so that is one of the important things. We are going to talk about the events and everything, but in the ATLS also there's something which is called the primary survey and the secondary survey. We will talk about that. Okay. Now, do not delay the urgent treatment for the lack of definitive diagnosis. So let's assume that the patient is not able to breathe, right? So it's okay. You can diagnose that, or let's assume that the blood pressure of the patient is very, very low. The diagnosis can wait, but at this point of time, you have to resuscitate the patient. So it's a very, very basic thing, but you have to kind of do the urgent treatment, whatever is needed to this particular patient. You can begin evaluation without a detailed initial history. So even if you don't have the entire history, the mechanism of injury, when did the injury happen and everything, you can still kind of begin your evaluation and the treatment of these particular patients. Now, as I told you, in the ATLS, what you basically get is we get a primary survey, and then what we get is a secondary survey. So we get a primary survey, we get a secondary survey. In the primary survey, the things which are included are rather small c, then A, B, C, D, E. Now over here, it has been written A, B, C, D. That's fine. That was something which is written in your Sabiston. But your 11 Billy mentions about this small c. So anybody, can you tell me what is this particular small c all about? So please try to understand this small c is basically control of external hemorrhage. So what is this? This is control of external hemorrhage. So whenever any particular patient is coming to you,
I found this on the.
goodbye Siri.
Until next time.
Sorry for this kind of interruption. So what I was trying to tell you over here, the small c is basically control of an external hemorrhage. Okay, external hemorrhage. This is what you need to understand about the small c kind of component of it. Okay, then we have an ABCD, that's all fine. Okay, now what is A basically standing for? A is basically for the airway. So whenever you come across a patient, and this is what is very, very relevant as a surgeon when you are evaluating the patients in the casualty as well, the first thing you basically do is you talk to the patient. And if at all the patient is able to speak, if at all the patient is able to tell their name, what happened, XYZ, it basically means that the patient's airway is patent and now you can move on to the next kind of a patient. But let's assume that the patient is having a bit difficulty in talking, or let's say you are hearing some noisy breathing or severe kind of facial injuries kind of present in these particular patients, or the patient is agitated. All these particular things may indicate a airway obstruction. Okay, so if at all the patient is able to talk to you in a nice manner, in a proper manner, all is fine. Okay, but if at all, let's say there is some difficulty in breathing and all those particular things, this indicates that probably there is an airway obstruction. Okay, probably there is an airway obstruction. Now simultaneously, you also have to kind of take care of the spine. You have to kind of transport the patients in what you call as a hard collar, Philadelphia collar, and you have to kind of assume that every patient might be having some spine injury, and you have to take that particular precautions with every kind of a patient. Okay, cervical spine protection. Assume all patients, all trauma patients may have a kind of a spinal injury. Use a hard collar, which is also referred to as a Philadelphia collar, and be careful when moving the head and the neck of this particular patient. So again, another important thing, what you basically use is a hard collar. You do not use a what you call as a soft collar as well. So what you basically use is a hard collar, the Philadelphia collar. Now, definitive airway of management. So if at all, let's say you assume that the patient is not able to breathe or something like that, then you can go with an orotracheal intubation or the nasotracheal intubation or something like that. Now let's assume that there is a patient of a head injury. Okay, and you suspect that there is a base of the skull fracture, or let's say severe maxillofacial injury. In that, will you do a nasotracheal intubation? Your answer should be no, right? So if at all there is a severe maxillofacial injury, the nasotracheal intubation is contraindicated because there is a possibility that there is a fracture of the base of the skull. And if at all there is a fracture of the base of the skull, when you pass a nasogastric tube, or let's say when you pass a kind of nasotracheal kind of intubation you try to do, there is a chance that your tube might enter into the brain and it might kind of cause injury to the brain parenchyma. In a similar manner, even the nasogastric tube is something which is not put if at all there is a severe maxillofacial injury with the base of the skull fracture. I hope you are able to understand this particular point. So yeah, definitive airway management. I hope you have understood. What you basically do is, if you do not suspect the base of the skull fracture, yes, you can go ahead and do an orotracheal or the nasotracheal intubation. Otherwise, if at all there is a severe maxillofacial injury, the emergency airway which you basically take into consideration is cricothyroidotomy, and the definitive airway is what you refer to as your tracheostomy. Okay, so whatever you can write in the airway in the kind of concise form, you can just kind of mention on this particular forms. Okay, check for the speech. If at all the patient is able to speak, airway is kind of patent. If at all you hear them noisy breathing or there is some major kind of maxillofacial injury or something, you suspect that there can be some kind of an airway obstruction. You use a hard collar considering that most of these particular patients might be having a spinal injury, and definitive airway establishment is critical. Why? So what you basically do is orotracheal intubation you do if at all the base of the skull fracture is not present, but if at all that is there, then you prefer to go ahead with a tracheostomy or a